This is actually the third part of the radiosonography course, and for Medina it is the second part. And here we missed the first part, which was about the chest X-ray and CT scan, and we are planning to deliver this part for you, inshallah. But now we are talking about the brain, and we will emphasize some of the anatomic landmarks as well as the diagnosis of the cerebrovascular lesions. And in order to have a CT scan of the brain, there should be some patient preparation. And the only preparation required is just let the patient to fast for about 4 hours to 6 hours. 4 hours for children and 6 hours for adults. And this fasting is required whenever the patient is going to be injected with contrast material, or he will receive some kind of anesthesia. Then when to inject the patient with contrast, we usually inject patient with contrast whenever we are looking for intracranial infection and the brain tumors. But no need for contrast material in cases of trauma and the cerebrovascular stroke. Then in order to have the scan, the patient will lie on the bed of the machine. This is the CT machine, and we'll start the examination by this image, which is known as the scanogram. The scanogram is just a plain X-ray for the part to be examined, and the value of this scanogram is to locate the area to be scanned. And we say to the machine, we would like to scan this part of the body from here to there. Then the machine will ask about the interval of scanning. Would you like to scan this area every 1 centimeter sections, or half a centimeter section, or else? Then in adults, we usually scan the brain every 10 millimeter or 1 centimeter, and in the children, we usually scan the brain every 7 millimeter scan interval. Then whenever you finish the scan, you will have these sections, and you're starting by the most inferior one at the skull base and going up until we reach the vertex of the skull. Then how can we know the details of these anatomic structures seen in the sections of the CT scan? The first of these anatomic facts is the fact that in the brain we have 4 ventricles: the fourth ventricle, the third ventricle, and the 2 lateral ventricles. Then the fourth ventricle is located inferiorly in the posterior fossa, then the third ventricle and the lateral ventricles, as you can see. And in order to know the anatomy, we should identify the ventricle, then we know the rest of the anatomy. If you look to this MR image, and you can see this is the brain tissue, and this is the cerebellum, and this is the brainstem. And you can see that the fourth ventricle is located between the cerebellum and the brainstem. And the fourth ventricle is big in its middle part, and it becomes smaller lower down, and also becomes smaller in the upper sections. Then when the fourth ventricle is large, and you see the largest part of the brainstem anterior to the fourth ventricle, and the brainstem is composed of 3 parts, as you all know: the medulla oblongata, and this is the pons, and this is the midbrain. Then if you have a section like this, and you are cutting in the fourth ventricle when it is large, you will see this is the fourth ventricle, and you know that anterior to the fourth ventricle is the brainstem, and the posterior to the fourth ventricle is the cerebellum. In the cerebellum, you have the left cerebellar hemisphere, the right cerebellar hemisphere, and in the middle, you have part of the cerebellum which is known as the cerebellar body, or the vermis of the cerebellum. Then, if you identify the fourth ventricle which is large, then you know that anterior to the fourth ventricle will be the largest part of the brainstem, which is the pons. Then this is the pons, and this is the left cerebellum, right cerebellum, and the cerebellar vermis. And anterior to the pons, you see a very important artery, which is known as the basilar artery. Then, if you look to these sections, this is the fourth ventricle, which is large. And if you go down, the fourth ventricle will be small. And anterior to the fourth ventricle, whenever it is small downward, this is the medulla oblongata. You remember, the small fourth ventricle inferiorly is posterior to the medulla oblongata. Then, you look here, this is the fourth ventricle, and you are going up. Whenever you are going up, the fourth ventricle will be also small. Then, this is the fourth ventricle, whenever it is small, but higher up in the section. Then you will see this curve, which is filled by CSF and is known as the quadrigeminal cistern. This quadrigeminal cistern is a very important cistern because it lies posterior to the midbrain. You know, this is the fourth ventricle, which is large, then this is the pons. And this is the fourth ventricle, which is small, then this is the midbrain because you are in the higher section. Then here are the three levels of the fourth ventricle. The fourth ventricle is large, then this is the pons. The fourth ventricle is small inferiorly, then this is the medulla oblongata. The fourth ventricle is small superiorly, then this is the quadrigeminal cistern, and this is the midbrain. Okay. Then after you are going up, you will cut in the lateral ventricles, and you are going like this upward. Then you have a section which is like this one, and see you this section like this one. And here you are cutting in the lateral ventricle. This is the frontal horn, and this is the third ventricle, and this is the occipital horn. Then look at the CT section. This is the frontal horn, and this is the occipital horn, and this is the third ventricle. Then you should know that this level where you can see the third ventricle is known as the level of the basal ganglia, because we have 4 basal ganglia in the brain. The dentate nuclei, which are located in the cerebellum, the caudate, the lentiform, and the thalamus are here in this particular section. Where can we identify the caudate nucleus? In this area. This is the site of the caudate nucleus in the concavity of the frontal horn. Then where is the lentiform nucleus? Here. This is the site of the lentiform nucleus. Then where is the thalamus? The thalamus is on either side of the third ventricle. Then we have 3 of the basal ganglia, which are the caudate, the lentiform, and the thalamus. Then this is the frontal horn, this is the third ventricle, and this is the occipital horn. Then if you look here, you will see a very famous structure which has a famous configuration between the caudate, the lentiform, and the thalamus, and this is known as the internal capsule. Then in this area, you can see this is the frontal horn of the ventricle, and this is the occipital horn, and this is the third ventricle. Then what do you think of this structure? It will be the caudate nucleus. Then what do you think about this area? It will represent the lentiform nucleus. Then what do you think of this particular? This is the thalamus, and this is the internal capsule. Very good. Then if you go slightly up, you will see these calcifications. And these calcifications are constant and consider normal findings in adults. Everyone who will perform a CT scan of the brain in adult patients will have these 3 calcific foci. The one in the middle is the pineal body, and the left and the right calcification in the occipital horn of the ventricle represent normal physiologic calcification in the choroid plexus inside the ventricle. Then if you go up, and you will cut in the body of the ventricle, and this is the body of the ventricle on the left side, and this is the body of the ventricle on the right side. Then you will see this is the left cerebral hemisphere, and this is the right cerebral hemisphere. Then going more up, you will not see ventricles, but you see only the cerebral hemisphere on the left and the cerebral hemisphere on the right. And you can see that the cerebral hemisphere is composed of two different colors. The central part, which is known as the white matter, and the peripheral part, which is known as the cerebral cortex, or the gray matter. Then the gray matter is the cortex of the brain, and the white matter is the, let us say, the medulla of the brain. Then, if you see a lesion in the brain, and you would like to say the exact site of the lesion, if the lesion is here, what do you say? Left cerebellar hemisphere. If the lesion is there, what do you think? In the bones. If the lesion is here, and this is the frontal lobe of the brain, and if the lesion is here, then you are cutting in the temporal lobe. Then this is the temporal lobe, and this is the frontal lobe, and here is the brainstem, especially the bones. This is the left cerebellum, and this is the right cerebellum, and the part in the middle will represent the body of the cerebellum or the cerebellar vertex. Then if you are cutting in the lateral ventricle and you want to know the lobar anatomy, then you draw two lines, one anterior and one posterior, and also in this section, one anterior and one posterior. And you know that the lobe anterior to the first line will represent the frontal lobe, and the lobe posterior to the second line will represent the occipital lobe. Then, what about the area in the middle? The area in the middle will represent the temporal if you are cutting below, and the parietal if you are cutting above. Then how can you know you are cutting below or above? Just look at the third ventricle. If you see the third ventricle, you are cutting below. If you don't see the third ventricle, you are cutting above. Then this will be the temporal lobe because of the third ventricle, and this will be the parietal lobe because of the body of the ventricle, and you don't see the ventricle itself. You don't see the third ventricle. Then, if you would like to locate the lesion in this section and you don't have the ventricles to draw lines, then you should have three lines, dividing this section into four parts. The first part will belong to the frontal lobe, but the last one will not belong to the occipital lobe, because the occipital lobe is very small and it finishes from in the lower section. Then you don't have here occipital lobe, and also you don't have the temporal lobe, and the rest of the section will belong to the parietal only. Then a part of the frontal lobe, because the frontal lobe is very big and it extends up in the sections, and the rest of the sections will be section will be belonging to the parietal lobe. Then, if you look to this section of the brain, and this is the normal brain, where you can see the normal size of the ventricles and the normal size of the cortical sulci. But look at this brain, this is what we call atrophy, brain atrophy. In brain atrophy, the ventricles are dilated and the cortical sulci are dilated because of the loss of volume of the brain tissue. Then the ventricles will dilate and the cortical sulci will dilate. And if we see this finding in old age, we consider it normal evolutionary changes. But if we see this in the pediatric age group, we call this atrophic brain changes. And this is atrophic brain changes, which are considered normal for adult population, old population, and you see dilatation of the ventricles and the dilatation of the cortical sulci. And you remember that this is the choroid plexus, calcification in the occipital hole, and this is the calcified pineal body. Then we came to the issue of the cerebrovascular lesions or the cerebrovascular stroke. And we'll concentrate on the diagnosis of intracranial hemorrhage as well as the diagnosis of ischemic stroke. First of all, we should know some of the terms used in the radiology report. Sometimes you read that we are dealing with a hypodense lesion, or a hyperdense lesion, or an isodense lesion. What do we mean by hypodense or hyperdense or isodense? That's to say we have a lesion, hypodense lesion is a lesion that is less dense than the brain. This hypodense lesion is less dense than the brain, meaning it is black compared to the normal brain tissue. And the hyperdense lesion is bright compared to the normal brain tissue. An isodense lesion is similar to the brain parenchyma, Then how can you know that there is a lesion here? And you don't see a lesion, but you see the effect of the lesion on the ventricle. If you look to the normal scan, you should see a left ventricle on the left, the right ventricle on the right. But if you see that the right ventricle is compressed and shifted to the left side, then you know that there should be a lesion here that has compressed the ventricle and displaced it to the opposite side. And since you don't see a lesion, you consider it an isodense lesion. Then, why the lesions appear hypo or hyper or iso? This is because of what's known as the density of the lesion, which is measured by the Hounsfield units. Hounsfield is the British physician who invented the CT scan. Then the units will measure the density of every tissue in the scan. And the normal density of the brain parenchyma measures about 30 to 40 Hounsfield units. Then anything below 30 will appear black, and anything above 40 will appear bright. And the CSF measures about from 0 to 15, then it will appear black compared to the brain tissue. And also the fat in the orbit will appear black, and the air in the paranasal sinuses will appear black. Also the cysts in the brain, because of their water content, will appear black. Infarctions will appear black, and the brain edema will also appear black. Then we have only two things which appear bright in the scan, and these things are the hemorrhage and calcium. Intracranial hemorrhage will appear bright than the brain parenchyma, and the calcification will also appear bright. Then whenever I ask you, how can you differentiate between the hyperdensity of the hemorrhage and the hyperdensity of calcium? And I hope you will say that the clinical picture. The clinical picture of a patient with an intracranial hemorrhage will be completely different than a patient with an intracranial calcification. And we also have some tools whenever you are scanning the patient, just to put your pointer on the lesion. Then the scan will read the density. Any brain hemorrhage will read below 100 Hounsfield units. Any calcium will read above 200 Hounsfield units. And these are the ways we differentiate. Then, if hemorrhage is going to be to occur inside the cranium, what are the sites for intracranial hemorrhage? Let us see this drawing, which shows the skull table, and this blue line represents the dura, and this red line represents the arachnoid, and this green light represents the pia mater, which is adherent to the surface of the brain. Then if hemorrhage is going to be occur, number one, it will occur between the skull and the dura, and this is known as extradural hemorrhage or epidural hemorrhage, or may occur underneath the dura, and this is known as subdural hemorrhage, or below the arachnoid, and this is known as the subarachnoid hemorrhage. And this subarachnoid hemorrhage will go inside the cortical sulci. Then the number 4, it will occur inside the brain parenchyma, and this is known as intracerebral hematoma, or inside the ventricle, and this is known as intraventricular bleeding. Then look at this section, which is normal brain tissue. You see, this is the normal brain, these are the ventricles, and here the cortical sulci filled with CSF. Then if you have a CT scan and you see the cortical sulci are filled with hyperdense blood, then you know that this is subarachnoid hemorrhage, because the hemorrhage here is flowing with the CSF. Then this is the subarachnoid space. And if you have a CT scan, the cortical sulci should contain CSF, which is black. But if the CSF is now bright, then you know that there is hemorrhage with CSF, and this is the diagnostic criteria of subarachnoid hemorrhage. Then look at this hematoma, and you see this hemorrhage is adherent to the skull and extending along the inner skull table. Then this hemorrhage will be outside the brain parenchyma. And there are two sites for hemorrhage outside the brain, the epidural site and the subdural site. Then how can you discriminate between both? This is a very easy procedure. Just look to the inner margin of the hematoma. If the inner margin of the hematoma is convex, then you are dealing with epidural blood. If the inner margin of the hematoma is concave, then you are dealing with subdural blood. And look at this epidural hematoma, and you can see a hemorrhage which is adherent to the skull base, and you see the fracture line, and you see the convexity of the hematoma, denoting that this is an epidural blood. And this is the classic appearance of a subdural hematoma with concave inner margin. There should be hemorrhage which is adherent to the skull and extending along the inner table of the skull. Then this hemorrhage would be epidural or subdural. Then we came to the intracerebral hematoma, which is a hematoma inside the brain parenchyma. If the hematoma inside the brain parenchyma is secondary to trauma, and this is known as cerebral contusion. But if it is due to hypertension or diabetes, it is just a non-traumatic intracerebral hematoma. Then the intracerebral hematoma will be close to the ventricle, and the wall of the ventricle is very thin. Then the hematoma has the chance to extend inside the ventricle, resulting in intraventricular bleeding. And this is an example. You see this hematoma, which has extended inside the ventricle and the opposite ventricle as well, resulting in an intracerebral and intraventricular hemorrhage. Then, does every intracerebral hematoma will extend inside the ventricle? No. And this is an example. You see, this is a hematoma without intraventricular extension. And this is another hematoma with intraventricular extension. And there is no rule for any hematoma to predict that it will extend inside the ventricle or not. It does not depend on the size of the hemorrhage or the age of the patient. No rule for this. But all what we do is just to comment on the hematoma. We see a hematoma in the left parietal region with no intraventricular extension. We see another hematoma in the right thalamus with intraventricular extension. Then if I asked you about the source of an intraventricular hemorrhage, the first source is a hematoma near to the ventricle and extended inside the ventricle. Then what about the subarachnoid hemorrhage? The subarachnoid hemorrhage is the hemorrhage circulating with the CSF. Then this hemorrhage will by time will enter inside the ventricle. Then we have two sources for intraventricular hemorrhage, which are the intracerebral hematoma and the subarachnoid hemorrhage. And this is the subarachnoid hemorrhage in the cortical sulci, and you see bilateral intraventricular extension of the hemorrhage. Then if you see the blood, the blood will appear bright. But by time this blood will lyse, then you got decrease in the density of the blood. So if the hematoma is acute, it will appear bright compared to the brain parenchyma. And if by time the hematoma will decrease in density until it is black to the brain parenchyma, then you know that this is chronic blood. And if the hematoma is exactly similar to the brain, then you know that this is the subacute blood. Then look at this hematoma, which is epidural or subdural.
Extradural.
Yeah, okay. This is extradural hematoma because the inner margin is convex. Then the extradural hematoma is usually seen in the acute phase only because the extradural hematoma is present in a very narrow space, and the patient will complain severely, then going fast to do a CT scan and then evacuation of the hematoma. But the subdural hematoma is present in a very wide space. Then you can see the subdural hematoma like this one, which is acute, and you can see the subdural hematoma, which is similar to the brain. Then you are dealing with subacute hematoma, or the chronic hematoma, which is black compared to the brain. And I know that all of you must confronted with the patient with chronic subdural hematoma frequently in the clinical practice. And that's because the hematoma is small and the symptoms are mild. Then the patient wait for some time, then the blood by time will be black to the brain parenchyma. Then acute hematoma will be bright, chronic hematoma will be black compared to the brain parenchyma, and the subdural blood will be, the subacute blood will be almost similar to the brain parenchyma. Then This is a subdural hematoma, which is subacute because it is almost similar to the brain parenchyma. And this is a subdural hematoma, which is chronic because it is black compared to the brain parenchyma. Then, what do you say about this hematoma? This is a subdural hematoma because of the concave inner margin. But the hematoma is composed of a black part and a bright part. The black part is considered the chronic blood, and the bright part is considered acute blood. Then we do not say this is a chronic hematoma, and we do not also say this is acute hematoma, but we call it the subacute phase. Hematoma with two components is in the middle. It is not acute and not in the chronic phase. Then if you see another hematoma like this, with part black and part bright, part black and part bright, and you know this is a mixture of acute and the chronic blood, and you call this a subacute hematoma, not acute, non-chronic. Then we came to the infarction, and the infarction is a dead brain tissue secondary to cutting of the blood supply. Then you will see an area which is dead in the brain. And you know that the infarction is not a specifying lesion. We know this fact. The infarction is not a specifying lesion. Then we do not expect that the infarction will compress the ventricle. This is true? Okay. Then if you see an infarction like this one, and you see the ventricle adjacent to the infarction is compressed, that is to say that the infarction is surrounded by brain edema, and the edema compressed the ventricle. And this is the acute infarction. The acute infarction is an infarction which is surrounded by brain edema, then it has the chance to compress the ventricle. Then we call this acute infarction. But after some time, this infarction will liquefy, and the brain tissue will be liquefied and transferred into an area of fluid density. Then the resultant will be loss of volume of the infarcted brain tissue. Then the ventricle adjacent to the infarction will dilate to compensate the loss of volume. Then whenever you see an infarction which is compressing the ventricle, you know that this infarction is associated with edema and it is acute. But if you see an infarction and the ventricle adjacent to it is dilated, then you know that this infarction is chronic and there is loss of volume compensated by the dilated ventricle. But if you see an infarction which does not affect the ventricle, nor by compression, nor by dilatation, then you know that this is the subacute infarction. Then acute infarction will compress the ventricle, chronic infarction will dilate the ventricle, and the subacute infarction will not have any effect on the adjacent ventricle. Then this is an acute infarction, and you can see hypodense area compressing the ventricle compared to the opposite ventricle, denoting acute infarction. And this is a subacute infarction because the ventricle here is almost similar to the opposite side. There is no compression on the ventricle nor dilatation. This is the subacute. And this is a chronic infarction, and you see an area with dilatation of the ventricle adjacent to it. Then, whenever you perform a CT scan for a patient with acute cerebrovascular stroke and you see normal findings, then you know that this patient does not have hemorrhage, but he may have an infarction. But this infarction is not well seen in the scan because the dead brain tissue takes some time to appear in the scan. And this is an example. This patient is examined in day 5 of August, and after 7 days you can see the area of infarction. But this infarction, which appeared sometime after the onset of the stroke, is known as infarction in evolution. And infarction in evolution, the maximum time for the infarction to appear in the CT scan is about 72 hours after the onset of symptoms. Then you see this brain is normal, and you expect that the patient will develop the infarction in the follow-up scans. But what to do if you see a normal brain and the symptoms of the patient are coinciding with the cerebrovascular stroke, and you would like to know where is the stroke in order to have some rapid management and so, then this is the value of MRI, which can see the stroke immediately after its onset. Then this is the follow-up of an infarction, starting in the acute phase, compressing the ventricle, and proceeding until the chronic phase with dilatation of the ventricle. Sometimes you can see infarction with hemorrhage inside, and this is known as hemorrhagic infarction. And there are two main causes for hemorrhagic infarction. The first one is venous occlusion, and if the vein is occluded and the arterial blood is coming normally, then the capillary blood pressure will be raised and some of the capillaries will rupture, resulting in an infarction with hemorrhage inside, and this is known as hemorrhagic infarction. The second cause for hemorrhagic infarction is arterial embolism, and you got an embolus, then dead brain tissue, then the body tries to lyse this embolus and to recanalize the vessel. Then a small hole will result in the embolus, and a gush of blood will go through this hole. Then it will rupture some of the capillaries, resulting in hemorrhagic infarction. Then if you see hemorrhagic infarction, you know that the underlying cause is one of two: either venous thrombosis, and you look carefully in the veins of the brain, or arterial embolism, and you look for the cardiac status of the patient. And an infarction which is less than 1 centimeter in diameter is known as lacunar infarction. The lacunar infarction, by definition, is the infarction which is less than 1 centimeter in diameter. And also infarctions can occur in multiplicity. And here, a patient with chronic infarction on the left and acute infarction on the right. And this case with two acute infarctions, one big on the left side and one relatively smaller on the right side. Then by the end of this talk, I will show to you some of the quiz cases, and I would like you to answer these quizzes. What do you think about this patient having a lesion on the right side and another lesion on the left side? Yeah.
Chronic infarction.
Yes, chronic infarction on the right side, and
with the intracerebral.
yes, recent intracerebral hematoma. Okay, yes. This is a good comment actually, and you see this area, which is, we call it in the radiology reports, an area of encephalomalacia. What do we mean by encephalomalacia? Is dead brain tissue, and the dead brain tissue may be the sequelae of infarction, and may be the sequelae of trauma, may be the sequelae of surgery, may be the sequelae of infection, and may be the sequelae of a previous hematoma. Then how can you know that this encephalomalacia is the sequelae of any one of I have mentioned? Then you should have the previous films and you should have the clinical data. But if you say this is a chronic infarction, you may be right. But if you know something about the history of the patient and you have the previous films, you can judge this area as an encephalomalacia of whatever etiology that I have said. Okay? Then what do you think of this case? Subacute subdural hematoma, left or right? Yes, this is bilateral hematoma, and you know the frequency of bilateral subdural blood is a little bit well known in the clinical practice. This is bilateral subacute subdural hematoma. What do you think of this? Yes, acute or subacute or chronic?
Chronic.
Acute based on the ventricle adjacent to the infarction. This ventricle is not seen, you see the choroid plexus only, and this ventricle is relatively dilated. Then the infarction is compressing the ventricle on each side. This is acute infarction. Then we'll show you some of the anatomy. What do you think of this? Calcified choroid plexus, and this third ventricle, and this. Yes, this is the lentiform nucleus, and what do you think of this? This is the right thalamus, and this? Minor body, very good, and this? No, this is the, yes, the caudate nucleus on the right side. What do you think of this? Acute intracerebral hematoma on the right side, very good. Okay, what do you think of this?
And extradural.
Yes, extradural hematoma in the frontal region. Very good. And what do you think of this? Very good. Subarachnoid hemorrhage. Then the anatomy, what do you think of this part of the brain? Frontal lobe, and this? Temporal lobe. And this is? Basilar artery. And this is? The bones. And this is? Yes, the vermis of the cerebellum. Very good. What do you think of this case? Epidural on the right side. Yes, very good. Epidural on the right side and subarachnoid on the left side. And this is actually a good association in trauma. You may got epidural hematoma and the subarachnoid hemorrhage in the same case. What do you think of this? Left infarction. Acute. Right?
Chronic.
Actually, this ventricle is compressed, then you know that this is acute infarction. But you don't know that if this ventricle is normal, because the patient had some atrophic changes, or if it is dilated secondary to the presence of this area. Then we consider, if they have the same density, we consider them as both acute infarction. Okay. Then what do you think of this? Okay, now compare this ventricle by this one. What do you think? Compressed, yes, this is acute. Then can you see some bright foci inside the infarction? Then you are dealing with an acute hemorrhagic infarction. And I thank you very much.